All right, hey everybody, this is Kyle Cox. I'm one of the orthopedic surgery PGY3 residents, and this is a talk on splinting principles and techniques. Over the years, some of y'all in the emergency department have asked us to do some either formal or informal teaching on how to put together splints, and ultimately the goal of this is to eventually do an in-person training session. But due to COVID, it's just been difficult to nail down a time to be able to do something in person. So hopefully this, suffices in the short term, and hopefully we can build this into something that we can reproduce every year in person. Hopefully y'all learn a little bit of what we think about when we put a splint on a patient and when we manage fractures in the acute setting. So hopefully y'all get a lot out of this. So here is our outline for what we're going to talk about. Let's start by considering some of the goals of care. Here's orthopedic Hippocrates, and I like to kind of call the Hippocratic Oath of orthopedic fracture care as, achieving immobilization without causing harm to the patient. So this is sort of something that is on the back of our minds whenever we're managing an acute fracture. Some principles and technical considerations. So why do we immobilize an extremity? So the obvious answer is for fractures and dislocations. In the acute setting, even though an injury might be operative, it's important to immobilize the extremity to prevent the soft tissues from incurring any additional injury. As you can see on this x-ray, especially when there's a high energy mechanism, there's a significant soft tissue burden that the patient experiences with a trauma, and with those bone ends that are sharp swimming around the soft tissue, it can cause additional trauma to the soft tissues that will impair healing in the long run. So once we get to an injury, we want to immobilize it as soon as possible to prevent this from happening. Also, and probably most importantly, when we see a fracture that can maybe be a candidate for non-operative treatment, our goal for immobilization is to create a splint with a mold that sort of prevents the injury mechanism, so we can prevent that fracture from moving and potentially becoming an operative injury. So things like distal radius fractures come to mind, ankle fractures, things that meet non-operative indications. It's important to put the patient in a good splint so we can maintain that treatment plan until they start to form callus and eventually heal their bone. Also, we use immobilization for soft tissue protection. The knee wound on the right you see is actually a knee laceration that was repaired in the ER with one of our residents. And unfortunately, they were not sent home with a knee immobilizer or some form of immobilization. So even though their original repair looked good, the patient went home and continued to arrange their knee. Eventually, their repair failed, the wound dehisced, and became infected. So a lot of the times we'll use immobilization of the extremity to protect the soft tissues as well. And then lastly, we use immobilization as a means for pain control. Even in an injury that's not necessarily a fracture, something like an ankle sprain, a patient could benefit from a cam walker boot or even a short leg splint for comfort in the short term, so that it can kind of get them through that original or the acute painful setting. Let's talk a little bit about splints versus casts. Splints are designed to be temporary. It's probably the main takeaway from telling the difference between a splint and a cast. Splints are made out of, they can be either prefabricated or manufactured from plaster or orthoglass. We use plaster here at South. It's that white sort of roll that you see us that will dip in the water, and then as that dries, it becomes hard and molded to the patient. We like plaster here because we feel like we can get a better mold with the plaster to the patient, and it can hold reductions better than orthoglass in our opinion. However, orthoglass is used very commonly in the community, and if y'all ever do any work in the community institutions, then you'll see a lot of orthoglass out there, and they both do just fine. It's just more of a personal preference from us that we like plaster more. So splints are not circumferential, and the reason why we like to use them in the acute setting is that it allows for swelling. As you can imagine, after an injury happens, there's a couple of days where the extremity will continue to swell, and the way that we build our splints using the plaster or the orthoglass, it will allow for some accommodation for that swelling. Also, they're sort of designed to be temporary. As you can see in the picture, they're covered in ace bandage, and then underneath there's only a few slabs of plaster underneath holding everything together. So eventually, if patients are walking on their splint or using it a lot, it'll eventually get kind of tattered and fall apart. So they're not really made to last a long time. They're really meant to be converted over to a cast in the short term. So casts, on the other hand, are made of fiberglass. They're much more durable and meant to last longer periods of time. They're circumferential, so they do not accommodate swelling well. So we do not like to use them in the short-term acute setting because there have been some reports of compartment syndrome as a result of a cast applied in the acute setting, and the post-injury swelling has not been accounted for. So they're usually meant to be placed as a transitional tool from a splint to a cast for the subacute setting for more long-term immobilization. So choosing your splint, there's going to be a lot more on this later, but the main goal to think about when choosing your splint is you want to choose the splint which best restricts the motion of the affected bone or joint. So take a distal radius fracture, for example. The motion that occurs at the wrist is flexion extension, obviously, but also there's some play with pronation and supination. So a sugar tongue splint works best for this injury because it comes up above the wrist or past the wrist to the metacarpal heads to prevent your flexion extension, but it also comes up above the elbow to prevent pronation and supination. Same thing for a short leg splint for ankle fractures. You want to eliminate as much plantar flexion and dorsiflexion as possible. We also want to consider inversion and eversion as a possible motion there. So the short leg splint does a good job of eliminating all of those motions for the goal of allowing those bones to heal with minimal motion within the splint. So we'll talk about this as we kind of go through the talk. But when constructing a splint, you want to make sure you have these 4 things with you before you start. The soft roll or web roll, as it's often referred to as, serves as your cast padding and serves as your first layer of protection from the plaster against the skin. You also have the plaster, which is what allows for immobilization and allows you to develop a mold. Orthoglass can also be used here. The ace wrap is sort of the covering of the splint, makes it look nicer. And if you're at Children's, you'll see that we use bias wrap also. The difference between bias and ace bandage is that the bias is less compressive, so Dr. Nimitz says, and so he thinks that it's has a lower incidence of causing compartment syndrome, although I've never seen compartment syndrome just from a splint. It does require tape, however, because it doesn't have Velcro like the ace wrap does. So make sure if you use it, you keep a little roll of silk tape with you as well. And then lastly, you want to make sure you have a bucket. The best use for it is that it's made to hold the water that you dip your plaster in, but also it's a great tool to be able to carry all your materials around with you to the patient's room. Let's talk a little bit about padding thickness. The goal for the thickness of your soft roll prior to applying the plaster is to have at least 3 layers of soft roll between the skin and the plaster. The reason for this is that as the plaster dries, it hardens via an exothermic reaction. So that heat can be transferred to the patient and cause thermal necrosis or other burn injuries if you're not careful. So they say that 3 layers is sufficient to protect the skin, and if it's too thin, you could run the risk of burning your patient. So when you do this, as you're wrapping, as you can see in the picture on the right, and later demonstrated in a video, that you want to overlap your soft roll wrap about 1/3 of the way, or 1/3 of the distance each time you go around the extremity. So you'll kind of travel, 1/3 of the whole width of the web roll wrap. Also make sure that when you're wrapping, you're avoiding wrinkles or clumps. These can cause pressure points within the splint, which can cause skin necrosis if not well padded or taken care of, or if the splint's on for a long period of time. You want to make sure that you pad all the bony prominences and also at-risk nerves, specifically the ulnar nerve in the upper extremity and the common perineal nerve in the lower extremity. Those are nerves that are fairly exposed in the subcutaneous tissue, and if they're not well padded, a hard splint compressed on that for a long period of time can cause a nerve palsy or a nerve praxia. But when building your splint, always err on an over padded splint to prevent those complications. But that's also not without its own risk, because an over padded splint can result in a less efficient mold, and you can risk losing a reduction and eventually converting a non-operative injury to a possibly operative one. If you can imagine, if there's too much padding between the plaster and the bone, it's not going to be able to hold it in place as well, because there's going to allow too much motion in that space. So take care not to over pad a splint as well. Plaster thickness. This is a little more straightforward. For upper extremity splints, we use 10 layers of plaster. For lower extremity splints, we use 12. The risk if you're too thin, or if you have too little layers of plaster, then your splint can be too weak. It might fall apart or lose its reduction. But if you have too many layers of plaster, this basically compounds the exothermic reaction we were talking about before, and can increase the risk of injuring your patient by burning them. So try to stay consistent when using your plaster. 10 layers for the upper and 12 layers for the lower. Water temperature, I like the temperature of my water to be about the same temperature as baby bath water. If any of you guys have kids or have given a kid a bath, you kind of have an idea about what's comfortable for the child. You know, you don't want the water to be too cold or too hot. So the same thing goes for plaster. If the water is too cold, the main risk for that is that it'll just take longer for the plaster to dry. As I mentioned, it's an exothermic reaction, so if you're starting at a colder temperature, it's just going to take longer to achieve that hardening. And we don't like that, because then we end up holding our splints together for a lot longer than we'd like, and sometimes you can fatigue and lose a reduction that you're trying to hold while the splint dries. On the other side, if your water's too hot, then you guessed it, you can cause thermal injury or skin necrosis to the patient if you're not careful. So always be mindful of the temperature of your materials. So after you've constructed your splint, it's important to make sure you know how to dip the plaster. I know it sounds simple, but the key is to get the whole slab of plaster wet. And then I give it a really good squeeze to squeeze out any extra water, and then we do what's called laminating the plaster. Basically, it's just giving it one last wringing with your two fingers, usually between the index and the middle finger, along the entire extent of the plaster. What this does is it A, gets out any extra water, B, it smooths the plaster out, so it kind of gets rid of any lumps or bumps or anything that can cause a pressure point in the patient, and it also reduces the number of holes in the plaster, which then increases the strength of the plaster itself, and will increase the strength of your splint. Like anything, you know, there's always good in moderation. So over laminating your splint can make your splint too dry, and can lose strength or harden too quickly. So just be a little careful by doing this. So I usually give it about 1 or 2 runs with my hand on either side before I'm done laminating. The mold, this is a little beyond the scope of this talk, but the general concept is to counteract the injury mechanism. So this is me demonstrating a 3-point mold, and we would use this for a distal radius fracture, for example. So on distal radius injuries, the mechanism is a dorsal displacement. So what you want to do is counteract that mechanism. So my top hand is pushing the hand volar, and then my other 2 hands are sort of bracing the extremity, almost like you're trying to break a pencil with your hands. You know, you have your hand on either side of the pencil, and your thumb is the middle, kind of counteracting those forces. So you can say here that my top hand and my leg are serving as my hands on the pencil, and then my left hand in the middle is serving as my thumb. And you're kind of thinking about that sort of mechanism when you're trying to hold a mold. And the key is to think about counteracting the mechanism by which the injury occurred. And this mold is what's going to hold the fracture or hold the reduction in place over time. So before you really start splinting, there's a little checklist that you have in your mind to make sure that you have everything that you need. Make sure that you've gotten all the films before splinting, and that includes the joints above and below your injury. Last thing you want to do is, get put a ankle fracture in a short leg splint, and then on your post-reduction films you realize they have a plateau fracture that you missed because they didn't see enough of the tibia or something. So make sure you're completing your imaging. Plan your reduction. Know what you need to do with your hands to manipulate the bones in order to reduce the fracture and sort of counteract that injury mechanism. Make sure you have adequate pain control, and also choose pain control which matches what kind of work you need to do. So putting a sugar tong splint on somebody with a non-displaced distal radius fracture is going to require different pain control than somebody who needs to have their dislocated ankle reduced, so make sure you have that in mind. Make sure you've got your consent done, especially at children's when you're dealing with kids. Most any sort of procedural work you do with kids requires a consent. I don't necessarily consent for every splint that I put on because not every splint requires sedation or significant analgesia. So if you're gonna do something that's gonna cloud your patient's judgment, make sure you do get a consent before you start working. If you need it, we do have a mini C-arm available to help you plan your reduction and make sure that you have a good reduction in the splint as it dries prior to getting your finals. And then before you start, again, double, triple check that you have all your materials. And then also some extra. The last thing you want to do is, once you started building your splint and your plaster is dipped and drying, the last thing you want to do is having to run out of the room to get more supplies. So make sure you have everything with you before you start. After splinting, don't forget your post-reduction x-rays. For us, if the reduction is inadequate, or if you can improve a reduction of an injury that can buy them out of a surgery, it's important to repeat it if it's not sufficient. If that's not a consideration, then make sure you get your post-reductions to confirm that you help the patient really. And then afterwards, after you've given them some medication or sedation, make sure you assess their recovery as well. For aftercare, make sure the patient has close follow-up. Educate them on the importance of RICE, so resting, icing, elevating, and compressing the injury to help with swelling and pain control. Compression itself is really achieved by the splint since we do wrap it with a compressive dressing, but it's important to talk to them about resting, icing, and elevating because when they come to clinic, most of the time they talk about how much their injury hurts, but a lot of times the folks that are compliant with this will be much more comfortable. Make sure you provide education on the risk of complications with splint wear and instruct them on what those are, the signs and symptoms of those complications, and tell them to come back if they experience any of those. Some pearls for the pediatrics world. I always over fortify my kids. Even if it's a distal radius fracture, when I put a sugar tong on, I usually carry that splint all the way to the fingertips, and maybe I'll put them in a posterior slab because kids will find a way to wiggle out of the splint that you make them. I've seen it happen. It's happened to me. You do not want that phone call at 2 a.m. So over fortify those kids. Make sure that the splint that you put on them is indestructible so they can't come out of it. And then always tell them that they can't shower or bathe or get the splint wet, because as soon as it gets wet, we have to take it down and replace it because it'll just fall apart. Regarding the size of the soft roll and plaster that you use, my general rule for me is for babies I use the 2-inch, for toddlers and kids I use the 3-inch, and adolescents and adult sized kids I use the 4-inch, which is the regular size that we use at the med center. But obviously there is some kind of wiggle room, so make sure you just choose the size that you think best fits your patient. And then, as I mentioned before, NIMIT prefers bias wrap over ACE wrap. because he thinks it's less constrictive. I don't know if there's any data on that, more of a personal preference, but it is a good use to sort of overwrap your splint and make things look nice for the kids. Unfortunately, yes, there are complications. We've talked a lot about this before, so I won't beat a dead horse. But the one thing that we mainly worry about when putting on a splint is causing burns or skin breakdown to the patients, also nerve injury. So making sure that your splint is well padded and smooth will prevent these things from happening. Also, there have been reports of compartment syndrome after a splint has been applied. Mainly this will happen if you pull the ACE bandage too tight. So when you're wrapping your splint with ACE, if you see the holes in the ACE stretching, you know it's too tight. So I usually would just lay the ACE bandage down so it's not loose, but it's also not constrictive. So talk to your patients about compartment syndrome before they leave the ER. The 6 P's of compartment syndrome, to kind of bring it back full circle, are pain, paresthesias, pallor, pulselessness, paralysis, and poikilothermia, or cold extremity. So make sure they know about this. So if they experience any of those symptoms, they can come back to the ER. We can cut the splint down and assess them. And again, make sure your splints are well padded. So we'll talk about some various splints that we use. Here's some upper extremity splints. Most commonly, y'all will see us putting on a sugar tongue splint, which is basically a U-shaped splint that goes from the volar aspect of the hand around the elbow to the dorsal aspect of the hand. Use this a lot for both bone forearm fractures, really any forearm shaft fracture, or distal radius fractures. A posterior slab is just one long slab of plaster that goes along the posterior aspect of the elbow of the arm at the elbow in 90 degrees of flexion. This is used for injuries about the elbow. Sometimes I'll add some sidebars to help with some varus valgus stability on the splint. A long arm splint is just a sugar tongue with a posterior slab combined. A coaptation splint is sort of a reverse long arm splint where the U actually goes around the humerus and the posterior slab is on the posterior aspect of the arm. I hope none of you ever have to put on a sugar tongue splint because they're very difficult, as I'm sure y'all have seen us do, but we use these for humeral shaft fractures. An ulnar gutter splint is essentially an intrinsic plus splint that just involves the ulnar aspect of the hand. The intrinsic plus is what I do is I kind of make a sandwich on the hand, a slab of plaster on the dorsal and volar aspect of the hand each that extends about to the mid forearm, and then I mold the hand into the intrinsic plus position, which is 45 degrees of wrist extension, 90 degrees of MCP flexion, and 0 degrees of IP extension. It's very difficult to get all the way to those parameters, but getting close is the goal. Usually you use these for metacarpal fractures, and you'll see us use them for Bach's fractures a lot too. Thumb spica, lastly, is basically a ring of plaster that we put around the thumb and then carry that proximally over the wrist volarly, and that's meant to mobilize the thumb and the adjacent joints. We use this for thumb-based fractures and scaphoid fractures. For the lower extremity, short leg splint is probably the most common splint that we apply. It's composed of a posterior slab and a stirrup, or a U, which will go around the bottom of the foot and up on either side of the leg. The posterior slab is just one single slab of plaster that goes from the plantar aspect of the foot up to the posterior aspect of the knee. A bulky Jones is essentially a short leg splint with bulky cotton. We'll use those for calcaneus fractures, as calcaneus fractures are notorious for causing significant swelling and skin breakdown. So we want to make sure we have as much padding as possible to prevent any skin injury or soft tissue injury as a result of that. A long leg splint is the same thing as a short leg, just extended up to the groin and the lateral aspect of the upper thigh. This is meant to immobilize the entire lower extremity. Mainly use this for tibia shaft fractures or length unstable tibial plateau fractures or other fractures about the knee. And then a J splint isn't something that we do all the time. We mainly use these for pediatric femur fractures that need to be immobilized in the short term. But that's essentially a long leg splint that comes up above the the hip up to the torso, just to provide a little bit of extra stability for the femur. So here is a video that we made demonstrating on how to apply a sugar tong splint. Alright y'all, I'm going to show you how to do a sugar tong splint. This is Roger. He's going to be my stunt double for the splint here. So materials for a sugar tong, you'll need about 3 rolls of 4-inch plaster. I do about 5 or 6 rolls of 4-inch web roll, and then 1 or 2 ace bandages, with one of them with a thumb hole cut in it. So I'll show you how to do that in a second. So before you start, make sure you have all your materials ready, like we talked about earlier. And then when you're measuring out your plaster, you got to make sure that you come all the way up to the metacarpal heads there, and then on the both anterior and the posterior aspect of the hand. So I always measure a little bit long, because you can always tear your plaster afterwards and shorten it. But when you dip and the water gets, or the plaster gets hot, it's going to shrink. So you want to be longer than shorter if you're going to err on one side or the other. So we've already got everything measured out. So I'm going to go ahead and start wrapping up Roger. First thing I do is I start at the wrist here. The key is you want to make sure you pad the bony prominences. So I pad the wrist for three or four rolls, and then I start traveling up to the hand, make a little tear there for the thumb, and then I wrap the metacarpal heads 3 or 4 times, tearing each time. That's 3. There's 4. Come back down, make a little tear at the top to cover the thumb, and then come back down through the rest of the forearm. And when you're traversing the arm, you want to cover about a third of, you want to translate about a third of the distance of your web roll or your soft roll, so you have adequate coverage. Because as we talked about before, if you have too little coverage, you could burn the patient as the plaster dries. Also, with web roll or soft roll, you can't tie it too tight, because if you pull it too hard, it's just going to rip. So you can be pretty aggressive with how tightly you wrap with the web roll. Just you want to be careful when you're wrapping your ace wrap. So when I get to the top of the arm here, I usually wrap about 4 or 5 times, just because that's where the end of your plaster is going to be, and you can get pressure points there. It can cause skin necrosis. And then what I do is, if you don't mind holding your arm up, usually I have an assistant holding you. What I like to do is I pad the elbow, because the elbow is another bony prominence that's going to cause some pressure points that could cause skin necrosis in your splint. So what I do is, we call it punching. I'll punch it 3 times, both kind of at the one here at top, one here in the middle, and then one here in the bottom. 3 times, and then do that 3 times. So you can have a nice pad at the elbow. 1, 2, 3. 1, 2. And then on my last one, instead of ripping it, I'll just kind of collect all my soft roll here, and then kind of cover any thin areas that I have. So I'll come back down to the forearm. You can see through your plaster. If you can see skin, you're too thin. So that's another way to gauge if you're they call it shadowing. If you're shadowing through your web roll, then you need to cover it with some more. So we're wrapped here. Got my, recheck my measurement here. I'm long, which is good. Make sure I have my water. Again, the water should be not too hot so we can burn the patient, not too cold, because then you're sitting there molding your splint for too long. So dip, give it one good squeeze, and then kind of wring it out. Call this laminating your plaster. Take 2 fingers and just kind of run it the length of the plaster to get all that excess water out. Just like that. Also, for sugar tongs, I make a little cut at the end for where the thumb goes, so when it molds, you're blocking your metacarpal heads there, and then your thumb has room to oppose, so it doesn't get obstructed or have any skin pressure there. So move it around. So again, I'm actually a little light in the hand there. I'm going to go back and put a little fold here in the hand. Something like that. I'll just wrap that on there like that, so a little extra pressure where the end of the splint goes. So again, right at the metacarpal necks, there, room for the thumb, Thanks, yeah. Wouldn't mind holding that for me. And sometimes you can get a nurse in the ER or somebody to help hold the arm for you. Or if you have a nice patient like Roger, he'll do it for you. So it ends kind of right where I want it. Go ahead and wrap it. You don't have to necessarily, go ahead and let that for me. You don't have to wrap with web roll, but sometimes it's nice because when you take the ace bandage off, after you take the splint off, that dust can go everywhere. So it's nice to kind of cover it with something. Also, I'll try to mold it to the elbow here to get a nice good mold so it don't slide off. Sometimes in larger patients, you don't have as good, I guess molding to the bone. Sometimes the plaster can slide off over time, so make sure you get a decent mold there. So cover with web roll. I'm going to cut a little thumb hole in my ace bandage. Something like that. And then here you're just trying to get your plaster covered, because as soon as you dip it, it starts drying, and then your time window for creating a mold starts to shorten. So once I get it covered, I'll start thinking about my mold now. So if this were a distal radius fracture, I would do a 3-point mold. Use your hand here. Essentially you pull traction, and then this hand just proximal to the fracture, this hand just distal to it, and then your knee as a 3rd point. Essentially you're going to push inward like that to get a volar mold on your distal radius. If it's a both bone, you're going to do an interosseous mold. Essentially find where the fracture site is, and then kind of compress in between the radius and the ulna to get tension on the interosseous membrane, and that should realign your fracture. And you essentially hold that mold for as long as the plaster is drying. We have a little saying that if you think your plaster is dry, hold for another 30 seconds, because the plaster still has some mobility even after you think it's dry. So you want to make sure that your plaster is nice and set before you let go of your reduction. But that's basically it. At the end, I try to make it look a little prettier, so I take another ace bandage, which fell, rewrap it, make it look nice for the patient, and then that's it. All right, y'all. Sorry about that. All right, here is a demonstration of a short leg splint. All right, guys, I'll show you how to do a short leg splint. The goal of this splint is to immobilize the ankle joint at 90 degrees, so essentially neutral dorsiflexion. So we'll get into how to get that positioned. First, let's go over our materials. Make sure you have your bucket of lukewarm water, about 6 rolls of 4-inch web roll, 6 rolls of 4-inch plaster, a 4-inch ace, a 6-inch ace, and then plus or minus a Curlex roll, depending on if you have an assistant or not. So first, let's measure out your plaster. The first component of your short leg is called a stirrup, or a U. Essentially what you'll do is position it on the base of the foot like this, and then have it extend up to the knee on either side. Again, you want to try to measure your plaster a little bit longer, because once it starts heating up and drying, it's going to shorten, and you don't want to lose length on your plaster. Second component is called a posterior slab. Essentially, you want the end of your plaster to end at the metatarsal heads, and then proximally extend up to the knee. So as far as positioning of the ankle, if you have an assistant, they can help you. The goal is to make the ankle at 90 degrees. So what I would do is, if you have an assistant, have them hold their elbow sort of in the crux of the knee joint there to bend the knee to 90 degrees. That's going to relax the gastrocnemius muscle and allow you to get some more dorsiflexion on your ankle. And they can hold this position while you wrap the leg. If you don't have an assistant, you can use a Curlex unraveled, just like this, and essentially wrap it around the toes. There we go. And then give it to the patient, and your knee bud, and have them hold it towards their opposite shoulder. So that way, have their knee bent 90 degrees, ankle bent 90 degrees, and they can hold it themselves while you're wrapping it. So I'm going to leave you like this. If you're okay, Raj, go ahead and start wrapping. So again, you want to make sure you're padding the bony prominences. So I start at the metatarsal heads, pad that about 3 times or 4 times, make sure I have enough thickness. And then I'll start traveling about 1/3 of the distance of my web roll to make sure I got enough coverage so I don't burn our patient here. Come back around the Achilles. Always kind of be checking in with your patient, making sure they're not falling asleep on you, or make sure you still have your right orientation of your ankle. So we got plenty of dorsiflexion here. Once you get to the top, right about where the fibular neck is, you want to pad that. You want to pad your common perineal nerve about 4 or 5 times. Make sure that when the plaster rests there, you don't get a nerve palsy. And then kind of come back and check and see where I'm thin. Now, just like with the sugar tone, what I do is I pad the heel and the Achilles tendon real well. So I'll pad the malleoli and the heel just like this, once there, once on the bottom of the heel, and then once over the Achilles, just like that. And I'll do that 3 times. Again here. 3. If I start losing my soft roll, I can kind of wrap it and hold it in place. 1, 2, and last one, 3. I'll take this and just wrap everything. Keep it nice and snug. You want to make sure you have no wrinkles, no step-offs, because those can cause pressure points that can cause skin necrosis at the end. Last, just check and see if I'm thin any places. So I'm a little thin up here, so I'm going to re-wrap. There, that looks pretty good. Again, making sure my ankle's dorsiflexed, my knees at 90 degrees. I can go ahead and dip. First thing that I dip is my U. Go ahead and dip it. Give it a good squeeze. Wring it out. Once or twice on each side. And then once you have it wrung out, sort of position on the leg like this. If you don't have any help, you can rest it on top of the leg here, just like that, and then reposition as you wrap it. So for the short leg, I like to kind of tack it down at the ankle once, and then reposition my plaster on the medial and lateral aspects of the leg. You all right, Roger?
Yep.
Good. Perfect. So once I got my U positioned, I'll get my posterior slab. Bring it out. Now positioning here is important. Come on down, bud. You want this to rest right at the metatarsal heads there. And then here, you can kind of follow yourself up the leg. Once you got it tacked down, just like this. Make sure you get a decent mold at the heel. There you go. Sometimes your assistant can help you with your plaster. And again, at the end, make sure your plaster's not touching the skin. Make sure it's got good web roll cover so the skin's protected. And over that. Now, I take the 4-inch first, wrap the foot, taking care to keep the toes exposed. And then, usually you have a lot longer distance to travel, so I use the 6-inch for the upper ace. And again, once you dip your plaster, it starts drying, so time is money, as I say. So I kind of try to be quick with this step. If you have an ankle fracture, all right, go ahead and let go, Raj. I'll take the leg now. What you want to do is keep the leg at 90 degrees to relax the gastroc, and then use your chest to kind of push and gain some dorsiflexion on the ankle. Just like this. For bimalleolar ankle fractures, you can sort of take them both together and squeeze like that. If you have an ankle dislocation, you can give it a valgus or a varus mold depending on where the direction of the deformity is. But essentially, this is your mold here. You can ask the patient to kind of push on your chest a little bit. That'll give you some extra dorsiflexion that way. And then you're given a little bit of a bimalleolar ankle mold like this. And then while I'm sitting here, I'll sort of tuck in the ace and make it look a little prettier. Just like that. You don't want Roger having an ugly splint where he can't continue his modeling career. And that's it. That's a short leg splint. All right. Well, that's it, guys. I hope y'all learned something today, and y'all will be receiving, or if you haven't already received yet, sort of a post survey. So if you don't mind filling that out, leaving us some feedback, letting us know what you liked, what you didn't like, what you think we can do better. We want to make this an enjoyable experience for y'all. And again, hopefully in the future we can do this in person, and you guys can get your hands on some splints and try to learn some things on a more hands-on fashion. But I thank y'all for your time, and I appreciate y'all for watching this video. I hope y'all have a good day.